We are live now.
Assalamu alaikum. Respected physicians, welcome you all in today's ECG study group presentation. Today is our 59th lecture session, and today we have a different type of presentation. Today our presenter is a cardiology resident student, Dr. Faisal Ahmed, who is being mentored by Professor M.J. sir. Before start of the session, I request Professor M. Athari sir to say some words regarding the presentation. Athari sir.
Thank you, Dr. Tushar, and good evening to everybody, and welcome Dr. Azizul Haq Bhai, Chaudhry Ahsan, Abdullah Jamil, and Professor M.J. Azam. Actually, I am happy to introduce Professor M.J. Azam. M.J. Azam is one of the leading interventional cardiologist, real academician, and I say he is the dynamic interventional cardiologist and real teacher. He knows what to do and when to do. So Professor M.J. Azam is really one of the leading, actually, cardiologist and one of the real teacher at present time. And I will request Professor M.J. Azam, I'm requesting you to introduce Faisal Ahmed, our beloved resident, cardiology resident. I will be happy if you introduce Dr. Faisal Ahmed, Professor M.J. Azam.
Azam sir.
Thank you, Athali sir. Give me the opportunity to introduce Dr. Faisal Ahmed Dorup. He is a MD resident, phase B student in our NSCVD. Now he is in the examining for the next session examining. And I believe he will be with you for next 20 minutes or 30 minutes with some interesting ECG. And I believe that will help us a lot to understand how to interpret ECG and correlate to the clinical significance of localization of the culprit vessel disease. So let's see how Faisal present his ECG, and I believe if any question raised to anyone's minds, please keep a note in your notebook first, then after the presentation, so we can discuss it details. Otherwise, if you discuss case by case, then it will take much more time. It may be required 1 hour more. So I request to everyone, you just put a note if any interesting issue is arise in your mind, so you can raise the question on after the presentation. So thank you very much, Athali sir, Abdul Wadud Chaudhry sir, and International Course Director, especially Ravi Kamal sir and Chaudhry Hafiz Ahsan. I think everybody, we should appreciate in this sorts of program, and through education, we should encourage it. Thank you very much, sir.
Thank you, sir. And now I request Dr. Faisal Ahmed to start his session. Dr. Faisal.
Is the screen visible?
Screen is visible. Please go to the slideshow mode and full screen.
Assalamu alaikum. Honorable Director Sirs, my respected teachers and dear learned audience, good evening and welcome to the 59th session of ECG study group. I'm Dr. Faisal Ahmed, a phase B resident of cardiology, and I'll be carrying out today's presentation, which is entitled as ECG localization of culprit vessel in STEMI. So before going to the presentation, I would like to share how excited I am to be able to present a case here. And I'm greatly indebted to Professor Athar Ali sir, Professor Abdul Wadud Chaudhry sir, and my mentor, Professor M.J. Azam sir, for giving me such an opportunity. So I'm going directly to my presentation. So my case starts with Mr. Shahjahan, a 65-year-old hypertensive smoker and non-diabetic gentleman who presented with chest pain for 6 hours. And on examination, patient had a pulse rate of 110 beats per minute, a blood pressure of 90/60 meter mercury with clear lung bases. These are patients presenting ECG. The ECG shows sinus rhythm with a heart rate of approximately 130 beats per minute. There is ST elevation in the inferior leads, where the magnitude of ST elevation in lead 3 is more than lead 2, and there is reciprocal ST depression in the precordial leads, whereas the ST in V1 is isoelectric, and the VT in the V2 there is ST depression. That gives rise to suspicion of possible right ventricular infarction. So later on, the right-sided ECG was done, and it shows ST elevation from V3 to V6. And there is also ST depression in one AVL, where ST depression in AVL is more than 1. So our ECG diagnosis is acute MI inferior with right ventricular infarction. So considering this ECG, what could be the possible site of lesion? So to have an idea of the site of lesion of the culprit vessel, these are angiographic views, the iliocranial view, showing there is proximal RCA occlusion. Also, the mid RCA is diseased, but probably the culprit site is the proximal RCA. So we should suspect proximal RCA occlusion whenever there is ST segment elevation in 2-3 AVF, and where the magnitude of ST elevation in 3 is more than 2, and there is ST segment depression in 1 AVL, where AVL is more than 1 in terms of ST depression. And if there is ST segment elevation in right-sided V3 and V4 leads, that gives rise to confirmation of involvement of RCA proximal to RV branch. So I'm going to the next case. My next case starts with Mr. Anwar Hossain.
Dr. Faisal,
Yes, sir.
sorry for interruption. I think it is better to discuss the cases. Then after finishing one case, then you should move to the next case. I think it will be better.
Okay, sir. Yes, sir.
I agree with that, because a lot of things needs to discuss in this case. I think it's better for the trainees to understand it better, how to deal with the proximal RCA occlusion with RV involvement.
So can you show the ECG please first?
Yes, sir.
Azizullah bhai, please.
The comment is there, we already discussed that. When the patient comes with this type of ECG, look at the clinics, okay? We pretty much discussed that the patient has definitely RC involvement, but the question about what's the location of that? Looks like the patient has location way up in the very proximal RCA. So you have to look at the clinical picture of the patient also. These two patients will pretty much, if there's RV involvement going on, what they're going to have, they might have elevated JVD, clear lungs. So look at the clinical picture, examine the patient. And when this type of patient comes to the ER, emergency room, we tend to give nitroglycerin with chest pain, right? So if you give nitroglycerin, the patient is going to drop. The reason being, RV serves as a conduit to the left side to get the cardiac output from the left side. If the RV is already down from the very proximal occlusion, make sure do not give nitroglycerin to this patient. It's going to drop the preload from the RV side, from the venous pulling, and then going to drop the cardiac output. Patient might drop further, blood pressure can go to cardiogenic shock. It's one of the main scenarios that we see to get cardiogenic shock in this type of patients when given nitroglycerin. And also this type of patients, what's the main treatment is going to be? Definitely fluid, more fluid. Just give a liter of fluid, 2 liters of fluid if necessary, because most likely this type of patient presents when they have very proximal RC occlusion, RV involvement, one of the main common reason of cardiogenic shock. So be careful to giving nitroglycerin. I'm giving the clinical side of that. So definitely we'll request further discussion.
So, Dr. Faisal, what is the explanation for the ST depression, the precordial leads from V2 to V6, ST depression?
Posterior probably.
Faisal, do you have any explanation?
Yes, sir. So, possibly there is a reciprocal ST depression also. It could be a posterior extension with ectoderma inferior. That could lead to the ST depression in the precordial leads.
The patient had most likely has huge RCA, like inferior posterolateral and RV extension, most likely.
Actually, sir, can I add one point, sir? Actually,
Yes.
the interest of this ECG to show here, because it should be considered firstly acute inferior posterior myocardial infarction to better understand. Number one. Number two, Dr. Aziz Bhai nicely pointed out, because our main motto in most of the inferior MI case, patients sometimes wants a hypotension with inferior MI. Our first initial impression, it might be have a RV infarction, then we should go for lung base, whether the depression is there or not. If lung base is no crepitation and hypotension, that gives us an initial clue that might be RV infarction. So we go for that way, but our recommendation in that particular situation, no nitrates, because most of the cases in ST elevation MI, non-ST MI, unstable, whatever the like, everybody very, very much comfortable to prescribe nitrates, but in that particular situation, you should not allow to give nitrates. That is the take-home message from this ECG. And as well, whether it is RV infarction are present or not, you have to search, because you can predict the prognosis. That's why that is important to understand this ECG. Thank you very much, sir.
So now let us discuss the ECG finding first. Chaudhary Hassan, when the ST depression extends up to the V6, can it be explained by the reciprocal change?
Hello, sir.
A couple of things. The magnitude of the ST depression that we call reciprocal, but if it is same elevation in 2-3 AVF and the same depression, then it's a matched. But sometimes it is disproportionately more, and the R is tall. So I don't know. You can call posterior here, but you definitely can call inferior and most likely RCA, as pointed out. And clinical scenario, whether EKG or not EKG, because I sometimes think that the ER just wastes time in terms of right-sided EKG. If the patient is not hypotensive, and then we can do all of that, but make sure that the treatment plan is already started, cath lab activated, STEMI people are on the way. Because if you look at the original paper with the inferior ST elevation, RCA dominant or SARC dominant, they add more criteria like lead 1 and AVL depression, but the sensitivity and specificity, none played that well. I usually do this because sometimes the STEMI becomes like a T20 cricket, because we have 90 minutes and already delayed, and I am now in the 80th minute, I have 5 minutes. So I decide that which guide I use, the culprit. So that last minute, because the ER wasted time, now I have to do the dot to balloon achieved in 90 minutes. And in our hospital, we now strive for 60 minutes. But then the guide is important, which guide you take to do the intervention. But clinically, that all Aziz Bhai said is very important. Has the patient, in general, I tell them, do not give any nitroglycerin in inferior. And in other way, other than in Hindi movie, nitroglycerin has no role in acute MI. Nitroglycerin has no role except if there is a pulmonary edema and the blood pressure is good, then you can give nitroglycerin. Nitroglycerin has no mortality benefit, zero. So it is a moot point of giving nitroglycerin in general, unless there is an uncontrolled hypertension or pulmonary edema with the blood pressure reasonable, then you can do something for the pulmonary decongestion. But otherwise, for pain, giving nitroglycerin in the face of STEMI EKG is a waste.
Can I add something?
Yeah.
What Hafiz Bhai was explaining is the scenario you can expect in a PCA capable hospital. But what is the condition in this country? Patient come, 99% patient come to a hospital which is not PCA capable. So we have to think about thrombolysis. In general, do not use nitrate in any inferior MI patient. Do not use morphine in any inferior MI patient. And that's the important thing. And if you're inferior MI patient, if you do not know how to do the right-sided ECG or you cannot do that in a hurry, just have a look at the blood pressure. The blood pressure is low. The patient is having ST elevation in some of the leads, but the lungs is clear. In anterior MI, if the ST elevation is there, the blood pressure is low, the lungs will be congested. There will be cramps.
Absolutely. Absolutely.
It's absolutely clear in case of RV infarction. So that gives you the clue, even without doing the right-sided lead, you know that you are dealing with an inferior MI with RV infarction.
Wadud sir,
Yes.
sir, just for the sake of the examination purpose, many of the time there's a frequently asked question that in face of RV infarction,
স্যার
you are
এখানে আতরালি স্যারের যে প্রশ্নটা ছিল স্যার অদূর স্যার অদূর স্যার ওই যে আতরালি স্যারের প্রশ্নটা ছিল যে B1 to B6
The thing is,
changes.
the changes that much we are seeing is very not expected in case of inferior MI with RV infection like this. This is too much.
And a question right now.
It can happen if the LAD has chronic occlusion and it is RCA dependent. And then if the supplier vessel, the RCA gets occluded, you will have some ischemia also in the anterior leads as well.
What was the question? Sorry.
Wadud, I have a question to you.
Yes.
This is we are advocating not to use morphine in inferior MI, but I didn't find in any paper where it is written. So it is practiced in NICBT and all the cardiologists practice it. But I use morphine in inferior MI, nothing happens unless the patient is hypertensive.
One point to make here, as for example, the inferior MI, we're most prone to see the AV nodal blood supply, and we see there's slowing down of the conduction system. But I think morphine could be given. It's not like absolutely you should not give it. That's not the motto. But you need to be careful about the conduction. If you see bradycardia, if you see 2:1 block or something, definitely not. Definitely not. No.
The morphine?
Yeah.
No. I beg to differ. Because how you control the pain in inferior?
Jamil sir.
No.
I use morphine.
I understand.
Yeah.
Hasan bhai, I use morphine.
Yeah. I support that.
But actually, the point is, if you have conduction defect, and what I am saying, the scenario where most of the doctors work, we are a specialist, that decision we can take, most of the junior doctors, they cannot take that. And they are working in rural centers or
how you control the pain in inferior MI with the conduction block?
Hello.
Instead of morphine, everybody, those who do not like to give morphine in inferior MI, they give pethidine. But pethidine is not a good drug to control the ischemic pain of the heart, and it causes if the pain is not controlled, lot of arrhythmias happens.
Yeah. The high grade AV block in the inferior MI may need a temporary wire, you can. I usually sometimes in a bradycardia I give atropine preemptively before going to the cath lab because I'm doing radial. Sometimes it's difficult to give pacer from the groin and I don't want to use this. So I just use atropine 0.5 and then go in and nothing happens. And usually, and I think for the pain control, morphine is the key.
Morphine is the best drug.
Yes.
And Dr. Hassan, normally when you deal with that in the interventional lab, when it's a very high grade, like very ostial RC lesion with RV involvement, Do you normally routinely use pacer temporarily when you do the angioplasty? Because we see that when you do the angioplasty, they sometimes do bradycardia with reflex, Bajer's reflex. They go pauses.
For the
Yeah.
complete heart block, I do.
Okay.
Because it's not going to complete heart block, I do temporary wear. For
Mhm.
high grade AV block, I do temporary wear. It's
Okay.
the sinus bradycardia or is Wenke back, then I use atropine and
Atropine.
take a chance.
Yeah.
Yes, yes.
That's all we do.
Sir, the question I was asking is that in face of the RV infarction, we are giving fluid. The question that is asked in the exam, in face of LV infarction, LV failure, why you are not giving fluid?
The answer is that, when you have RV infarction, you have to look at the blood pressure. If the blood pressure is good enough, 120 or something, you don't need to give fluid. The blood pressure is marginal, like 90 or something, that means RV is failing to supply the preload to the left side. Then fluid is the choice. Before even goes to the cath lab, give a couple of liters of fluid to maintain the cardiac output, because the low preload from the right ventricular side, because RV is not contracting well. But in the LV infarct, in the patients already in pulmonary edema, you don't want to give too much fluid, okay? Because most likely in major anterior MI, if there's significant LV dysfunction, you will have, a pulmonary edema, quite likely. Then listen to the lungs. If there's Clarkles, you don't need to give fluid. But then you can do vasopressor if necessary. But they need to go to the cath lab quickly as possible.
Can I add something? Look at LV infarction. In case of LV infarction, the LV cannot give out the blood that is coming from the lungs through the LA. That means there will be backflow into the lungs. There will be congestion. Now you are giving fluid that will go into the venous side, into the RA through the RV, into the lungs. So there is already backflow from the LA, and you are putting more fluid integrity through the RV, then you are producing more congestion, more failure. That's why we do not give fluid in case of LV failure. But in case of RV infarction, it's the Starling's law. You give out the fluid, you stress the RV, it will, the more you're stretching you put, it will, within physiological limit, it will contract.
I think it
That's
is
the
important
way.
to do an echo in this situation, because we cannot just take it. If you have the echocardiogram, it is better to understand, because RV, we say fluid, but RV is resilient, we know. But there is a limit that RV can handle. Because if it is a big RV insult, and usually late presenter of RV, just fluid will not cut it.
You will need
and in those cases, if you do the hemodynamics, you will see the RA pressure is less than the pulse pressure of PA. So the PAPI will be less than 1, and the RV is really failing. So in that case, I'm talking about the extreme. So yes, vast majority of the cases you will be able to get away with 500 and a liter max, but then you may get trouble. And also it is important to know with the echo that there is any other mechanism like PAP muscle dysfunction and MR, because that can compound the problem. So any patient in our lab, any patient with hypotension and STEMI, regardless of the location, I say do not go to we do not waste time, but we do echo right away. It's just to know and understand the mechanism of hypertension. It is very critical to know the patient, why the patient is in shock. Any patient without nitroglycerin, more than half an hour, blood pressure less than 90 is technically cardiogenic shock. And it is critical to understand cardiogenic shock by bedside echo before we do any intervention. Very, very important.
Remember that the posterior medial muscle is supplied by the RCA. So in case of RV infarction, RCA occlusion, if this papillary muscle is damaged, there will be MR. And that will be one of the critical reasons of hypotension. That's what Hafiz Bhai was saying. And that's very important to understand. And the echo is the key to understand that.
Dr. Faisal, What is the
Yes, sir.
angiographic finding of the left system in this case? That is
Sir,
related.
I didn't include the left system because the left system was insignificant. There was some non-critical lesion in the LAD, but other than that it was normal. As there are too many cases and too many angiographic views, I didn't actually wanted to make it more clumsy by adding both the system in angiographic views. That's why I just added the angiographic views that having the site of lesions.
Okay, thank you.
I can add actually LED seems to be 60 to 70% lesion, but not significant. Clinically, not 90-80% like lesion. So it is actually I understand what is your query actually. Why we want to B6 so much ST depression? Can you explain it is only by reciprocal change? Your answer is no, because inferior MI, in case of inferior MI, more than 30% case multivessel involvement. So in that situation, if you look at this V1 to V3 ST depression, it may gives you clue, maybe L6 also involvement. And if you want to V6 or V3 to V6, maybe LED, but not sure. So you have to make sure by coronary angiogram, and that is actually double vessel disease. This case.
That's another question. Another question. Do you have any old EKG on this patient? So they have significant LVH with ST abnormality to begin with in lateral leads, like reciprocal changes? Because I see the disproportional ST depression in all the leads, particularly lateral leads.
Yeah. So this is the maiden ECG the patient presented with. Actually,
Okay.
patient didn't have any.
Ajit Bhai, can I add something?
I have a
One of
question.
my observation is that if an inferior MI patient have tachycardia, then it's very likely that patient have triple vessel disease or LAD involvement. Can pure RCA involvement without where the LCX and LAD is normal, very unlikely to get tachycardia like this.
Unless the patient is in shock. I'm not sure what's the blood pressure of this patient.
And what do they shock? Actually, one of the thing in the acute MI is saying that VT is bad, bradycardia bad, complete heart block bad. But I get more worried with sinus tachycardia.
Yes.
Because sinus tachycardia tells you that I'm sick, fix me. This is more worrisome.
Patient is in shock, most likely, yeah.
Yeah.
Exactly.
So
Exactly.
I don't know, Azam, I had a question for you. So,
Right.
I have a question. The circumflex was good.
Circumflex, not too much critical disease. It is just like 30, 40, or like 50, not more than 50 actually.
So basically, all explained by the RCA. That you're saying.
RCA, right?
So I have a bad question. One of my partner, he does the RCA, sees the lesion, fixes it. So he doesn't look at the other side. Do you have any comment on that?
Definitely.
You always look at the other side before you do intervention? Or you fix it?
But actually, what is the golden rule? Once you see it is STMI, it is you are predicting is RC culprit. Okay, what is my practice? I just go the diagnostic for left system, and I go for the right catheter. But if diagnostic catheterization shows no significant disease, I straight away go for the guide catheter with the RCA, then I fix it up, then came back. But I don't know why he fixed it right first and he don't approach the left system. Actually, it is individual.
Basically, his argument is that he goes after the culprit right away, and then he decides about the.
I think he is pretty conservative to treat only higher infiltrated artery. Otherwise, he can't go for if need multivessel disease, complete revascularization. It doesn't matter to him either he go for the same sitting or the next sitting. Actually, his initial thought is he should fix up the infiltrated artery.
Actually, the multivessel revascularization in the same sitting is not now recommended. It causes more harm.
But
rather do the other vessels just before leaving the hospital. In the second,
yeah, there is shock. If there is patient in shock, then multivessel PCI.
So let me tell you,
in that case, if you do the culprit vessel, the patient usually comes up. Shock usually comes
Jamil
up.
sir, with due respect, there is a complete trial. If you look at this complete trial, you can fix it up if you look at the complete trial, question is whether you go for the same sitting or the index hospitalization or for within the 42 days, you can fix it up. That depends
Right,
on
right.
the
I do agree with the trial, but I do not do practice with a single trial. If it comes in the practice guideline or if it comes in the meta-analysis, then I will practice it.
Okay, now
That is my
I actually
strategy.
asked a different question. Azam, you're right, but I'm asking the question that when you do the STEMI patients, you see anterior or inferior, and then you go with the guide, and then you fix the culprit first without looking at the non-culprit. So do you like that sort of strategy? Okay, so I'm telling you that my view on this is very important, because I tell the fellows that you need to have a idea about the complete coronary anatomy.
Yes.
Very important. Particularly, this is not even acceptable in cardiogenic shock. You need to know the total coronary anatomy. And the second, to change the guide and take a picture, it doesn't take that long. So why not look at the anatomy? Because when you are doing PCI on a culprit vessel, if the non-culprit is threatening, you may get into trouble. So I know the complete trial is coming, and there is the question about multi-vessel in STEMI, but I follow simple rule so far, but it is controversial that you need to do the multi-vessel critical if is it a threatening vessel. If it's a threatening vessel, I do it in the same index procedure. If it is not threatening vessel, but critical but significant, I try to do this in the same hospitalization. If it is something stable, that patient after the STEMI walks around 10 minutes on the hallway, no problem, I do the index procedure, the stage procedure as an outpatient within a couple of weeks. If you look at all the data, all the events happen is if you delay this too long. That's why there is this whole thing. And it all comes into play. Patient's comorbidity, iodine contrast load, your radiation dose, all these come into play. Whether you are fatigued or not, that is also important.
Yeah.
So, sir, can we move the next case? Because, if we discuss case by case, it will take 30 minutes more, right?
That's why you wanted to discuss at the end.
Yeah, that's why,
Can I proceed? Yes, sir. My next case starts with Mr. Anwar Hussain, a 50-year-old smoker gentleman who presented with chest pain for 6 hours and dizziness. On examination, patient was having extreme bradycardia with a pulse rate of approximately 40 beats per minute, with a normal blood pressure of 110/70 meter mercury and cleared lung phases. These are patients presenting ECG. The ECG shows a heart rate of approximately 40 beats per minute. There is clear AV dissociation with variable PR interval that makes it a open and shut case of complete heart block. There is also ST elevation at the inferior leads. The magnitude of ST elevation in 2 and 3 is somewhat equal to each other. And there is reciprocal ST depression in the precordial leads. And there is ST depression in the 1 and AVL, where the ST depression in AVL is more than 1. So the ECG diagnosis is a case of acute MI inferior with posterior extension with complete heart block. And right ventricular infarction was excluded by doing the right-sided ECG. So to have an idea of the site of lesion, I'm sharing the angiographic views of the patient. Here's the yellow cranial view showing normal RCA, but there is no posterior descending artery arising from the RCA. So this is the left system. There's a ariocaudal view showing there is a lesion just distal to the OM view in the left circumflex that's giving rise the posterior descending artery. So this is a culprit lesion that caused the acute MI inferior with complete heart block.
So can you back to again ECG, please?
Yes.
Yes, this is ECG. Faisal, ECG to chole asho.
Yes.
Faisal, for our
sir.
participant, we have got the we have got the good number of residents, fellows in this program for their learning purpose. Can you actually tell me the ST elevation in millimeter in lead 2 and lead 3? How do you calculate? How do you measure? What is the system? Lead 2 and lead 3, in which lead is more? That is ST elevation.
Sir, the lead 3, the ST elevation in lead 3 is more than lead 2 in case of millimeter. The smallest number in the square we actually count. Where the ST elevation in lead 3 is more than lead 2.
So the question is, why do you count the ST elevation? It's 80 millisecond from the junction. That's the point you actually measure the elevation.
Too small.
Too small square. That's what Akhtar Bhai was actually alluding to.
So this is clearly that is more in the lead 3, na?
Yes, sir.
Athali sir, এই যে কোশ্চেনটা হচ্ছে স্যার আপনি যেটা বললেন যে লিড 2 থেকে লিড 3 ইজ মোর, তো এটা একটা ইন্ডিকেশন হচ্ছে যে মোস্ট লাইকলি আরসি ইনভলভমেন্ট। But if you look at this one and AVL, if AVL is much more than ST depression than 1, it suggests for it most favor for LCX. Moreover, if you look at this V1 to V3 ST depression, that also give you additional clue might be LCX is much more involvement. So thing is that, but you are not certain that is RCA or LCX, but more point in favor for LCX. But we should approach first right, then we should consider for the left. That is, sir, the usual approach in that particular ECG, sir. Any comment from other expert?
Sir, can I say something?
Yes, you can.
Sir, if the ratio of ST depression in the precordial leads and ST elevation in the inferior leads is more than 1, it indicates a possible LCX occlusion.
Right.
There is actually a dilemma because some features favor possibility of lesion in the RCA because the ST depression, the AVL is more than 1, and the ST elevation in lead 3 is more than 2. But the ST depression in the precordial leads is more in magnitude of ST elevation in the inferior leads. So,
Hafiz bhai, can you add any point?
It could have been an
I think, if I'm not mistaken, there was a Chinese paper that looked into this ST elevation business. You know, Marriott classically taught us this, and it is now, and therefore in the here we are not emphasizing that anymore because the Chinese paper, I think there is one other paper also showed that this sensitivity and specificity, as I told earlier, is not that reliable. So this debate of ST elevation, is it inferior RCA or circumflex? I think it is a mute point. The more important thing is that, is it involving RV? Because that's prognostically significant. When there is an inferior MI with significant RV dysfunction with the indication of posterior, the mortality goes up in hospital mortality. Otherwise, historically, if you look at the ICS data, inferior MI is pretty well tolerated compared to anterior MI, unless there is a shock, hypotension, RV. So I look at that way, and you can do a posterior lead or 16 lead in the back to get this posterior idea about, or the right-sided lead for the RV. But clinically, it is much more relevant than debating all day about is it RC or it is CERC. you are going there, you know that it's not going to make a whole lot of difference. And importantly, in this case, I don't look at anything. I just, if the patient is hypertensive, quick echo, rush to the cath lab, put a temporary wire first, because that is safety issue. Because once you start without doing pacemaker, we interventionalists, we have a problem to get venous access, and we make a big mess after anticoagulation. So I usually say that get the venous access, get a temporary wire. If I'm not sure, doubtful, at least I get the venous access. But in this case, I will definitely put a temporary wire, because as you inject, it may go into further problem.
One thing I want to ask, in this case, could it be possible that the involvement is only in the RCA, and these reciprocal changes are due to lesion in the circumflex?
There is ST segment depression. I don't see any tall R wave, and then ST depression, and upright T wave usually indicates posterior involvement. I don't see that. Isolated posterior is very rare, meaning that there is no inferior change, only precordial tall R wave and ST depression. Isolated posterior is very rare, and if it happens, usually circumflex is the culprit. But usually we see infero-posterior more likely.
স্যার একটা কোশ্চেন আসছে স্যার, যে আমরা যদি অ্যালাউ করি জুবায়ের এনাম চৌধুরী, ওকে কি রিভু একটু পুলে নিয়ে আসতে পারবে? পুলে না, কি বলে,
You can ask question, yeah.
প্যানেলে ওকে নিয়ে আসো, কোশ্চেনটা করুক। জুবায়ের এনাম চৌধুরী, রিভু, রিভুকে শুনতে পাচ্ছ?
জি স্যার, আসসালামু আলাইকুম। জি,
জুবায়ের এনাম চৌধুরী একটা কোশ্চেন করেছে, তুমি ওকে প্যানেলে নিয়ে আসো, আমরা ওর কোশ্চেনটা শুনি।
ওকে ওকে স্যার।
জুবায়ের এনাম চৌধুরী।
So in the meantime, in case of inferior MI, whether the involvement is RCA or whether the involvement is LCX, does it really matter too much?
স্যার, উনি আছেন, কথা বলতে পারবেন।
হাফিজ ভাই আনসার দিবে নাকি আজিজ ভাই আনসার দিবে এটা?
Now that question, let me তুষার যে কোয়েশ্চেনটা করেছে আর কি, জিনিসটা হচ্ছে কি, it really matters only matters when the patients that Dr. Ahsan Chaudhary mentioned, that when the patient has RV involvement in inferior MI, because that's more critical in the management issue. But otherwise, you are going to, in this case, particularly this case, when the patient has complete heart block, and whether you need to do a posterior ECG or right side ECG, I think we need to go in as soon as possible, and we need to put a temporary wire first. It doesn't matter really to look for where is location, where is the disease located, because you need to shoot for the RCA. That's your initial thinking, and then you need to go to the left circ, left system. That's the ideal way they do it. I'm not sure it makes any difference in a practical sense when in real-time scenario you want to intervene in this type of patient.
Thank you. Dr. Hafiz has also got the same comment, really, I think.
Okay.
Dr. Zubair, are you in? Dr. Zubair?
Tushar question
Yes,
is
sir.
that whether any makes sense, any difference RC or LCX?
Yes, prognostic point of view, if he has isolated posterior MI, a lot of patients really don't even feel it that much. Because a lot of time we see the patients having occluded left circ, they do fine. They have some minor, problem, and they can walk through that MI. Sometimes they're very atypical presentation, not much typical presentation. Sometimes they have, unless in acute phase that we missed it sometimes. This posterior MI, isolated posterior MI is missed most commonly. That is true, but we need to be careful to diagnose that. If you have any question, you need to do a posterior ECG. If you have time, not this situation. This situation is very critical to go in as soon as possible. But sometimes ECG presentation is very subtle in the posterior MI, isolated posterior MI, very subtle. Okay, and those situations we miss it, and definitely we should not miss it. And if you have any doubt, the patient had clinical presentation suggestive of acute coronary syndrome, and you don't see much on the ECG, very subtle changes like in ST changes in V2, V3, or in this area, then do a posterior ECG. But if you don't have time in this situation, go straight to pacer wire and go intervention.
Dr. Jubair?
Dr.
Sir, I
Jubair,
can hear,
please.
sir. Sir, I can hear, sir.
জোবাইর তোমার প্রশ্নটা করো।
So my question, sir, can I explain, sir? 1 week back, sir, one of my relative has admitted with, sir, 55 years old, no previous risk factor other than positive family history and smoking, obesity, no comorbidities, admitted with acute inferior MI within 6 hours in a PCI capable center. But somehow tenecteplase was initially given, and subsequently 2 days later, angiogram was done, and it was found that RCA long segment blockage along with significant blockage in LAD and LCX. In that case, my question is, what should be the revascularization policy for this patient after 48 hours after this tenecteplase? And if complete revascularization is done in this case after this 48 hours, what is the class of recommendation for this case? Thank you, sir.
It's a clear question. Professor Abdul Wahid Choudhury?
স্যার আমি তাহলে একটু স্যার বলি, আমার সাথে বোধহয় কেউ এড করতে পারবে। আমি জোবায়ের first question, the first issue is in HDMI, our main target goal, salvage the myocardium in the form of reperfusion strategy, most preferably primary PCI. If not possible due to any other cause, like in COVID situation, what happened in your case, maybe lytics is given, but reperfusion is the mainstay of the treatment. First thing you should remember, number one. But question is, your patient underwent angiogram 48 hours later on, but in index hospitalization, coronary angiography is indication to see the coronary anatomy. But within 48 hours, in certain situation, you even go for revascularization strategy by primary PCI or early invasive strategy or routine PCI strategy. You can do it. If you look at the first AMI trial, they said better late than never. Even in 48 hours, you can revascularize. That is much more better than thrombolytics or who don't give the primary PCI protocol. Mortality rate benefit is much more better than PCI strategy other than other strategy. So in that particular situation, after 48 hours, there is no literature, there is no recommendation go for the revascularization strategy by intervention. And I think if any point need, Dr. Hafiz Bhai can add.
No, I think this is the whole thing that about lytics, but sometimes in the PCI hospitals, we'll give lytics rarely because the cath lab is busy and not available. But the question is, it's a generic question that after lytics, whether PCI hospital or non-PCI hospital, how soon after that you should go? We used to wait, but now the guideline says you don't need to, particularly if you can go from the radial, bleeding risk is much less. We usually follow 44 hours to 24 hours time. So it is better to do that way, but you can go immediately. But if you want to do the reference, it's a German trial, CAPTIM, and they used 4 hours and the bleeding risk was not that high and it was good. And why we do this? Because, and this is a class 1 indication to do CAP after lytics. The reason is it is the volcano that ruptured. Now you need to find out that what happened and what the volcano can re-rupture. And this is the reocclusion after lytics is a very critical issue, and reocclusion has higher mortality, even in the best hospital, if you cannot tackle it right. So that's why the need for a cath and pacify the plaque with PCI stent after the lytics. Question is, if it is too late, what do you do? And at that point, you may see people differ. But I think the most logical thing will be to go after the culprit artery and then still fix it. Because if there is deperfusion established and the residual plaque and the lesion there, it may cause trouble in future. And then you can look at the left side or the other non-culprit as you do otherwise. Lately, I'm doing IFR also in these patients, in the non-culprit.
Hafiz bhai, after 48 hours, the situation is developed. Either he go for revascularization or not.
Right.
But one thing we should remember, actually, once infarction, that at least 1 hour, golden hour, if we intervene, then we can achieve at least 90% salvage. But if you look at after 3 hours, we can achieve at least only 40% can myocardium salvage. But 3 hours to 24 hours, only 10% myocardium may viable. But with the good faith to achieve something better, so we should go for revascularization strategy. Do you agree with me or not?
Yeah, because those old rules, we are little lenient now, because myocardial infarction is not conceptually like we occlude the artery and whole myocardium dies. It goes what we call the wave front phenomena. That means there is an epicenter of infarction, and around that there is a wave front. It takes about 4 to 6 hours to complete the infarction. Now, after that, there is a peri-infarct area that is also threatened. So we have seen this, we all have seen this, that if we leave the occluded vessel, sometimes there is an infarct expansion or infarct extension, because it may cause more infarction, or it can go fibrosis. What Dr. Narula, my mentor, used to say that, it gives cell-to-cell signaling, and then peri-infarct area, they undergoes apoptosis, and you see the LV deteriorates more than the artery supply itself. That is a complex, controversial area. I'm not going in that, but it is better that, as Azam said, that we intervene as early as possible and take care of the culprit artery at least, and then think about the non-culprit depending on the lesion and the physiology and anatomy.
Another comment I'd like to make, definitely, as we see, there's a reality probably in Bangladesh, that when the patient gets acute MI and when they present to the hospital, even in PCI capable hospital, the patient presented about after 12 hours, looks like that I'm not sure exactly, but thrombolytic therapy was given at 12 hours, according to the description I'm getting. On the other hand, looking at the anatomy, we do not have the details of the anatomy of the coronary. They mentioned that long lesion in the RCA, that's probably the culprit because present with the inferior MI. But he also has left circ and LAD disease and mentioned significant. We do not know how significant it is, how bad it is, and what's the location of that. Whether it's in a proximal LAD or proximal circ, that's also important to know. And what's the ejection fraction at this point after 48 hours? And whether the patient has concomitant other medical diagnoses like diabetes, whether the patient has diabetes and the patient has LV dysfunction and very proximal disease, LAD, circ, we need to have better anatomy of that. Then the question comes to whether like multivessel revascularization is an approach possible after 48 hours, or the patient needs to go for open heart surgery with bypass. So these are the things into consideration needs to be given when we manage those patients.
One thing is that we know from the New York State database that following MI, and the surgeons always will do this to you. Even if you refer to the surgery, they will buy time.
Ask for viability.
Yeah, so I call it natural selection because it is better, honestly, I mean, it is really better to take care of the culprit in the acute MI setting and not to send for surgery immediately, because usually they kill them.
So, Professor Azam.
Sorry, I don't think there is any surgeon here. I don't want to be. I don't want to be mean. And cardiogenic shock, always better to buy time, and buy time in patient's favor.
So, Professor M.J. Azam,
Yes, sir.
that's an excellent discussion. I will request Dr. Faisal Ahmed to present one more case so that we can enjoy a few cases from Chaudhry Ahsan. And I will request Chaudhry, that is Faisal Ahmed, to present rest of the cases in another session. So one more, I will request Faisal to present one more case. Professor M.J. Azam.
Okay, sir.
Sarvai, maybe we can ask Dr. Faisal Ahmed the rapid fire to finish his cases, because we are old. We don't need to, the people don't want to listen from us. We need to listen from them, the young guys.
Okay, Faisal, continue.
Sir, actually, I have 8 different cases with 8
Yeah.
different site of lesions. So probably it would not be possible today, but I can present the next one.
Yes.
It's a bit more interesting. I guess it.
আমার মনে হয় সেটা ভালো হবে, কিন্তু ফয়সাল তুই এগুলো পরে কিন্তু আমার দেখায়ও।
হ্যাঁ, আরেকদিন we can
Okay,
arrange মানে
আমি
another
কিন্তু দেখতে
session for
চাই
Faisal.
এই যে তুই সুন্দর দেখাচ্ছিস।
অদু স্যার, আমি এই জন্য বলছিলাম স্যার যে যদি আমরা কেস বাই কেস ডিসকাস করি দ্যাট 2 ঘন্টা লেগে যাবে। এই জন্য
তাই তো
বলছিলাম
দেখতেছি। You are right.
না, আচ্ছা,
You
লাগলে
are
তো
right.
সমস্যা নাই, কারণ ডিসকাশনটা ইম্পর্টেন্ট, লাগুক, অসুবিধা নাই। You will present in another.
Maybe I can make a suggestion. We allow 3 minutes discussion maximum, or no discussion at all.
না, discussion is important, Hafiz bhai. Otherwise, cross discussion learning is much more beneficial for our fellows.
But his slide set is good. He's teaching us.
Sir,
Faisal, তুমি কন্টিনিউ করো, আর একটা কেস দেখাও।
Yes,
Okay,
sir.
I'm going to my next case.
Sir, can we do a second thing? That is, he is showing all the inferior MI cases.
No, not inferior.
No, sir. Actually, I have included.
I'm not saying that. I'm saying that first 2 cases are inferior MI. So, and the discussion is already lively and extended beyond 1 hour. So, if the discussion is more on the next case, can we arrange a second lecture, which will
Yes.
involve the anterior MI cases and the
Yeah.
different lesions?
Yes, good proposal.
That is interesting proposal, right?
Actually, my third case is actually a bit mixture of both the cases. Actually, both acute MI anterior and acute MI inferior. So.
Okay, yeah, I think that will be interesting, sir. I think.
Okay, Faisal, continue.
Okay, proceed.
Okay,
Last
Faisal,
case. Okay.
go ahead.
Okay, sir. So, Mr. Asghar Ali, a 55-year-old smoker, hypertensive and non-diabetic gentleman who presented with chest pain for 10 hours with shortness of breath. On examination, patient had features of cardiogenic shock with acute left ventricular failure. So these are patients presenting ECG, showing there is the rhythm is sinus rate is approximately 78 beats per minute. There is widespread ST elevation, sparing the V1, and after that there is widespread ST elevation both in the precordial leads and also in the inferior leads. And if you see that the magnitude of ST elevation is progressively increasing from V2 to onwards, and in terms of inferior leads, the ST elevation in 2 and 3 is somewhat equal to each other, but there is ST depression in 1 and AVL, where AVL is more in terms of ST depression than 1. So what could be the possible site of lesion? Because the ECG shows there is acute MI anterior and inferior. So now I have included both the system. These are right system. The iliocranial view showing the LED is occluded from the mid segment, and the iliocranial view on the right side showing that RCA is occluded just proximal from the RV branches. So the both system is involved, and both system giving rise to a double wall MI. So what could be the culprit vessel? So the PCI was done. This is the right system, the RCA, and this is the LED. Now, after PCI, the actual form of LED is visualized, and in angiography, we're seeing that the LED is large and that is going beyond the apex, what we may call a wraparound LED. So if you're having an ECG with both the acute anterior and inferior, we should always be suspicious about wraparound LED. And actually the culprit artery is a proximal LED, but also there are some clues. If the ST elevation in a lead 3 is more than lead 2, it suggests proximal RC occlusion. If the ST elevation in V1 is more than V3, it also suggests proximal RC occlusion. But if there is progressive ST elevation from V1 towards V4, it suggests a wraparound LED. Probably it was the case in the angiographic view.
Good case.
Looking at the coronary angiogram, let's put that again, the very first two picture, and display that. And as we see, there's not much flow in the LED. And on the right side, can you play the right side? Right, RCA? RCA has some collateral flow going on, but distinct flow. But since it is wraparound LED, an occlusion of that is causing like secondary ST elevation in the inferior area. That's most likely. Okay.
Dr. Shahia, please.
Couple of things in this kind of situation where the EKG changes are not explained by only one area. So possibilities are, is it extensive wraparound LED that is giving this, or is it a multiple plaque rupture in two different areas at the same time? Extremely rare, but can happen. And you can read Richard Conti, Clinical Cardiology, his article on this. And then third is, there is a CTO, and the CTO was deriving the blood supply from the LAD, for example, and then now LAD is in trouble, so it raises the ST elevation in the inferior lead. This is called the distant ischemia elevating the ST elevation. But here, it is a tough call because definitely the LAD looks like culprit. RCA, you can't tell, because there is still dye-seeking. So I would congratulate the operators that after fixing the LAD, I hope they did the LAD first. I would do the LAD first in this situation, because it's cardiogenic shock, there is more money in this. I don't know, maybe you had the patient on Levofed or some pressors, but here we definitely would be giving something in terms of supportive, because it may not get better. Anyway, that is another talk, but I hope that you did the LAD first and then did the RCA. I don't know what was the order, just curious.
Okay, Hafiz bhai, nice.
PCI
Pointed out.
PCI was done by Professor M.J. sir.
Okay, I can tell you. Actually, this is the hypotension, and I just scared about the complete heart block occurred or not. That's why I just fix it up immediately right first. Then, but after fixing right, there is no improvement, clinical improvement, and no, there is no symptomatic improvement. That's why I just straight away go for then left. Actually, it's conceptually, this case particularly, we have to address first left system. After finishing my procedure, I can conclude myself that if I address the left, that will be much more better. Actually, I did in right first, then I go for left.
Good judgment comes from bad experience.
Bad experience. That's the thing. But my question is that in the panel or learned audience or faculties, actually, which one is the culprit? Which one is the culprit? Actually, after the procedure, we can understand LED is the culprit. from the ECG, it is very tough to make comment which one is the culprit vessel. Sometimes we have to depend.
LED, the single lesion in the LED can explain this ECG.
Right.
Because wrap around LED can give us this sorts of diseases.
From this ECG, it seems that the LED is the culprit as because this high elevation of the ST segment in comparison to the inferior lids. So most likely the LED is the culprit lesion.
Yes, sir, because I understand after doing the complete the procedure. Once I
But I tell you one thing, that you had some slow flow in the LED and some slow flow in the RCA, right? And you can, but I had one case where both vessels are occluded, simply occluded. So now you figure out, and they had some biventricular VT.
Hafiz bhai, I had a case, patient having inferior myocardial infarction in another hospital, then came to my hospital with anterior MI after 2 days. Then I could think the patient should have a single disease in the LED, that is wraparound, and that's what I could get. And I would start there in the LED, and that I fixed up.
Yeah, I mean, as I told you, it is better to go through a differential, that it could be a single lesion, or it could be CTO with collateral, or it could be simultaneous plaque rupture.
Jamil sir has a question. Jamil sir, can we explain this type of ECG by a single vessel disease?
Maybe.
একটা question করেছে আজকে আমাদের একজন Dr. Minaz.
That is by wraparound LED.
Right.
I have got one patient who have presented with this kind of ECG, and I did the PCI. The LED covered up to the crux, wrapping around the apex. It went up to the crux. So the RCA was non-dominant, but not L6 was the dominant. The LED covered whole the heart. So that was a massive attack for that patient. At that time, we didn't started primary PCI, so the patient had quite damage.
So there's another explanation which I don't want to say. Sometimes very rare, but I had one patient from Bosnia has this, and I still have that EKG on the slide, that anomalous coronary, the left coming from the right, giving the multiple area infarct. And it is because of the STEMI situation, we just intervene, you know.
So yes, that may be if in that case, if the occlusion is the proximal RCA and LED arrives distal to that point, then it may cause.
That is correct, yeah.
But very rare.
Very rare.
আমি মনে হয় ওয়াদুদ স্যার এবং আতালি স্যারের যদি পারমিশন দেন স্যার, আজকে আমরা ইসিজি তিনটে জায়গায় স্টপ করি, আর হাফিজ ভাই স্টার্ট করুক। আমরা অন্য আদার ডেতে আমরা এন্টোরিয়ামের ওই যে সেপ্টাল, ডায়াগোনাল, প্রক্সিমাল, ডিস্টাল গুলো আলোচনা করতে পারবো স্যার।
হ্যাঁ আজম, সেটা করো, কারণ এটা খুব ইন্টারেস্টিং সব ইয়ে হচ্ছে ইসিজি গুলো। বিউটিফুল কালেকশন।
বাট আমার মনে হয় যে আজকে তো অলরেডি রাত, না?
আমি খুব বিপদে আছি, সব এই নাই, নেট নাই, কারেন্ট নাই দেখে হটস্পট দিয়ে চালাচ্ছি।
স্যার
should we do anything or
স্যার আজকে
দু তিনটা ইসিজি দেখান।
Okay, so I need to share this.
Thank you. তুমি তোমার স্লাইডটা স্টপ শেয়ার করো।
I will finish in 15 minutes maybe. If I can share this.
Sir, meanwhile, sir, regarding the previous presentations, Wadud sir, I have a question to you. Wadud sir, sir, in most of the places of our country where there are almost no facility of primary PCI or PCI, the patient who comes with inferior MI with hypotension and severe chest pain. In those setup, our physicians, how they will approach without the support of, without not giving morphine or pethidine? Is it feasible or practicable?
A very real question, because in the Upazila Health Complex, you do not get morphine. You do not have morphine in those hospitals. You do not have even pethidine. And do you know what they sometimes use? They use Nalbam, another opinion analgesic. That has, in no books ever will say that you are going to use it in MI. But you have to do something. You have to get rid of the pain. You have to give some relief to the patient. Oh, please.
Because sir, this we should give the message to our participants as what they should do, because majority of the participants or majority of our physicians, or we also may not be able to treat in the well-equipped centers all the time. So where there are resource constraint, we have to adapt some policy to treat such patients.
I agree. Yeah.
Sure.
And it's important to give this aspirin and anticoagulation, but also to call around and to know that it needs further care.
তুষার, এই যে এসটি এলিভেশন এমআই ম্যানেজমেন্ট প্রোটোকল গুলো কিন্তু কান্ট্রি স্পেসিফিক হওয়া উচিত। হ্যাঁ, এটা ধরো রিসোর্স কি আছে সেটার উপর হওয়া উচিত, নাম্বার ওয়ান। নাম্বার টু হচ্ছে যে একটা এসটি এলিভেশন এমআই যদি হয়, এটা কোনো সন্দেহ নাই যে আমার চিকিৎসার মেইন উদ্দেশ্য হচ্ছে তার তিনটা চারটা উদ্দেশ্য থাকে। একটা হচ্ছে স্যালভেজ অফ মায়োকার্ডিয়াম, যত তাড়াতাড়ি সম্ভব আমি এটা করবো। মানে আমার যদি উপজেলা ধরো ঝিনাই দেওয়া হয়, যদি আমার পক্ষে সম্ভব না হয় আমি লাইটিংস দিব। আমি যেভাবে পারি আমি সেটাকে মানে চেষ্টা করবো রিভারব্রেশন করার জন্য। তার সেকেন্ড পয়েন্ট হচ্ছে পেইন রিলিফ করতে হবে, কারণ এই পেইন শোকে সে পেশেন্ট মারা যাবে। এখন পেইন আমি কিভাবে করবো, এখন আমাকে পেইন দেওয়ার সময় ইন্ডিকেশন কন্ট্রাইন্ডিকেশন দেখতে হবে। মরফিন যেটা বলছো বা ধরো এগুলো হচ্ছে সব 2A ইন্ডিকেশন, ইট ইজ নট এ ক্লাস 1 ইন্ডিকেশন, 2A ইন্ডিকেশন। এখন কথা হচ্ছে যদি ইনফিরিয়র এমআই সাবসেট, হাইপোটেনশন সাবসেট, মরফিন হাইপোটেনশন করে, রেসপিরেটরি ডিপ্রেশন করে, বাট ইউ হ্যাভ টু আন্ডারস্ট্যান্ড, ইউ হ্যাভ টু ট্যাকেল, এবং এটা যদি তোমার দরকার হয় তুমি দিবা বেনিফিট এবং রিস্ক রেশিও অ্যাসেস করে দিবা। 3 নম্বর যেটা হচ্ছে এমআই হওয়ার সাথে সাথে আওয়ার্স টু মিনিটস, মিনিটস টু আওয়ার্স টু ডেজ, এর মধ্যে ইনফাক্ট হচ্ছে, স্কার টিস্যু ডেভেলপ করছে, এরিথমোজেনিক ডেথ হচ্ছে, এটা প্রিভেন্ট করার জন্য আমরা বিটা ব্লকার অ্যাজ সুন অ্যাজ পসিবল স্টার্ট করব। ফোর্থ থিংস হচ্ছে যে এই যে ইনফেকশনটা হচ্ছে, রিইনফেকশন হতে পারে। হ্যাঁ, ইনফাক্ট এক্সপানশন, এক্সটেনশন, রিইনফেকশন হতে পারে। এটা প্রিভেন্ট করার জন্য আমাকে এসি ইনহিবিটর, ভেসোডাইলেটর যত তাড়াতাড়ি সময় অ্যাড করতে হবে 24 আওয়ার্স এর মধ্যে। এরপরে হচ্ছে তো আমাদের মেইন এসটিএমআই ট্রিটমেন্টের যে টার্গেট, দুটো টার্গেট থাকে, একটা হচ্ছে ইপিগার্ডিয়াল আর্টারিকে যতটুকু ফিক্স আপ করা, আর দুই হচ্ছে যে করোনারি অ্যাথেরোস্ক্লেরোসিসটাকে আমরাকে ফার্দার প্রপাগেশন যাতে না হয় সেটা স্টেট করা, সেটা যেন আমাকে স্ট্যাটিন দিতে হবে। তার সাথে আমাকে কি করতে হবে, নিউয়ার যে অ্যাডজুভেন্ট যে থেরাপি যেগুলো আছে, যেমন অ্যান্টিপ্লেটলেট দিতে হবে। তাহলে ABCD এই 4টা জিনিস মনে রাখতে হবে, অ্যান্টিপ্লেটলেট, বিটা ব্লকার, ডাইলেটরস, কোলেস্টেরল লরিং এজেন্ট, এই 4টা জিনিস দিতে হবে। তার সাথে রিপারফিউশনটা আমাদেরকে এনশিওর করতে হবে, আর পেইন ম্যানেজমেন্ট করতে হবে। এখন এটাকে কাস্টমাইজ ওয়েতে ন্যাশনাল গাইডেন্স নিয়ে যাওয়া যেতে পারে, অথবা ন্যাশনাল গাইডলাইন তৈরি করলে সেভাবে একটা আপডেট দেওয়া যেতে পারে। এটা আমাদের পলিসি লেভেলে যারা আছে তারা চিন্তা করবে।
Thank you, Professor.
Ajam, I think now we go on the second session.
জি স্যার।
Professor Havid Bhai, would you please start?
Yeah, so I will go fast, and I can show some remaining cases another time because it's already getting late. So this is a patient post cabbage, and day 2 went into this rhythm. Any comments for him, anyone? So Rafiq Bhai is not here. So I have a rule. If the EKG tracing looks like pulse ox, then it is VT.
But sir, there are some clues that it may not be VT.
What is the proof?
Sir, if I'm not saying, but if you sir look, sir, if you look the upper strip,
So look at this. These you can see my pointer. There is a captured bit, fusion bit.
Yes.
This is very wide, and
Yes, sir.
wide complex tachy in a patient who has coronary disease, until proven otherwise, it is VT.
VT.
And then the patient degenerate into VFib, and then shocked, and then resuscitated. And this
Yes,
was
sir.
the patient's earlier coronary anatomy: Lima to LAD, vein graft to dia, vein graft to PDA, and vein graft to OM given. And EF somewhat dropped after this surgery. And this is the EKG after the resuscitation. And this is day 2 after cabbage. What to do now?
What is the electrolyte level?
Potassium is normal, magnesium is normal.
Sir, what was his initial ECG, sir?
Initial
rhythm
EKG, I
Initial
don't
before
have
op-
it. Yeah, but this is the post, and there is no remarkable change. He had right bundle appearance in the pre-op
Bifascicular.
EKG.
He has, sir, bifascicular
Bifascicular.
definite, and
Yeah.
maybe
Right.
trifascicular. We can say if we AVF, as the amplitude is not much
Right.
than the one, so we can
Right.
easily say that is trifascicular block. So if
Well,
we have the
I use the term trifascicular, but our EP doctors, they don't like trifascicular. So, basically, what you are saying, that first degree AV block, and then right bundle or left axis or right
Yes, sir.
anterior right axis. But
So-
after this EKG, patient's blood pressure somewhat good, and he is maintaining okay. What is the next move?
So
This is
actually,
pre-op EKG. What's about the post-resuscitation?
This is the post.
Now-
Post. This is post.
One
Oh,
question we have, Dr. Hassan, looking at the R wave amplitude in V5, V6. This is the post-arrest ECG, right? Okay. The R wave amplitude is pretty low in V5, V6. The question right now, whether he had prior R wave low amplitude or this is new, whether he lost any anterior graft or something, there's a concern
Yes,
about that.
that's the question.
So
And I see some ST elevation there in lead 3 AVF little bit.
So
Okay.
I was telling the fellows, don't even show me the EKG. Patient goes to the cath lab.
Yes.
This is don't even show me the EKG. Patient goes to the cath lab, because this is a very ischemic event following post cabbage. So what I'm saying, we don't need to put too much, but there is ischemic changes, as you pointed out. But this patient goes to the cath lab, and then this is the cath. So slow flow in the RCA, and then slow flow in the circumflex OM, and then a couple of diagonals, and then Lima had slow flow.
My God.
So
How did it happen?
How did it happen? But the question is, you need to know, like, we need to know what happened. If not, then we cannot fix it, right?
Mhm.
So what to do next?
Can I see the angiogram again?
Yeah.
That's not. Can play. Let's see.
The only thing is that the Lima graft, if somehow the fellow did not load it, but Lima was not working.
Okay. Yeah, I think Lima definitely down.
What to do next? And the post cabbage, if there is a problem like this, we should not be hesitant to take the brave step to do the cath and then fix it, whatever needs to fix. So the next step is call the surgeon, that, hey, what happened? And then he says, well, the Lima had a little kink. And I said, well, the kink is now a big problem. You need to go back and open it. The other option is that if I were able to negotiate the Lima, and I've done these few cases where there is a suture point, acute problem after the graft is basically suture issues or graft failure and thrombosis. But here it was the surgeon admitted kink. I said, you need to go back, maybe give a free REMA to the LAD. But he went there and removed the kink, and then patient got better. So let me show you one other case, 47-year-old. Yeah, 47-year-old with a major depressive disorder, alcohol abuse, and came in with this.
QT is very prolonged.
Oh, what is magnesium level?
Yeah, that's correct.
So she remained conscious at this point, and hemodynamically stable. This is happening recurrently. What to
Prolonged
do?
QT syndrome, yeah.
QT is very prolonged. Right?
Yeah.
And probably he's taking some medications, so you have to look at it, whether there's any QT prolonging
Because he's
medications
psychotic
there.
patient.
Yeah.
So I would want the electrolyte, magnesium, and the medication list.
Most of the tricyclic antidepressant causes prolonged QT interval.
After the slide before, yeah, this one. No,
47-year-old, because I'm warming you up for the next case. So 47-year-old with seizure disorder, CNS vasculitis, alcohol use, and then came into our hospital. This is the EKG. You know, Rafiq Bhai is not here. We call it sinus tach. And then when in the hospital, cardiology was not involved. But when this happened, cardiology got involved.
Probably patient is in flutter, looks like. Let's see, I'm not. Oh, okay.
Oh.
Okay.
So this is polymorphic VT. And then we resuscitated the patient. And then normal coronaries. What do you want to do?
What about his ejection fraction and LVIDD?
EF normal, EDP normal.
Post-resuscitation ECG, can you see that?
You can look at this left side.
EF is bad. EF is 20%.
No, EF is good. And the QT is not prolonged. So we could not find any cause. Last case, we did not give any ICD, but this case, we could not find long QT or any other cause. So we actually protected the guy with the ICD, maybe controversial. So I was actually waiting to see what Rafiq Bhai would have done. And then the last one I'll show you, 63-year-old with dizziness, and he denies any previous MI or anything. This is the EKG, sinus rhythm with PVC. And then this. So white complex tachycardia, the differential is like VT, SVT with aberrancy, bundle branch block with tachy, and the pace rhythm. Aziz Bhai.
It looks like it's bypass tract involved here, because I see that a base of the QRS is a little bit different. There's some most likely that's the case. I'm not sure, but I'm looking.
It is a white complex with accessory pathway.
Yes.
Yes.
Yes. Sir, it's VT, sir. Sir, it's VT, sir, because the amplitude is the same. If we follow the lead V4 or V5 or V6, the amplitude and the duration of the QRS doesn't vary too much. And if we follow AVR, the first inciting, the first beat that goes in tachy is not the pre-excited beat. straight or going to VT.
And
I also differ with Aziz Bhai because there are some few normal complexes.
In between, yeah, I'm looking at right now.
Peer interval, QRS complex, all are normal. So there is no evidence of pre-excitation. And if it is concealed pathway, it's very unlikely to involve the pathways because concealed pathway behaves like the AV node. And his bundle, like, it always gives only retrograde transmission, not antegrade transmission. If the pathway are involved, in that case, the white complex this type of tachy may happen only in the manifested pathway.
And sir, if you don't mind, sir, if you follow the lead to rhythm strip, the last part, which is the white complex tachycardia, the first beat of that last part, there's the fusion beat. Is
Yes.
the in between white
Yes.
QRS and narrow. So it was more in favor of VT.
Yes. And then I had another trick I did, but I don't know you saw it. Look at the rhythm strip here when he was not in VT. We all will agree that the lead 2 is a PVC. Lead 2 and 3 PVC, right? Because this is and this PVC looks like left bundle. So this is probably inferior axis RV. So this is a classic RVOT tachycardia. And these are sensitive to, and in the exam, they give you another trick that the transition is dramatically different in the V3, V4 or not, then it can be LVOT tachycardia because this is inferior axis. But here it is RVOT tachycardia. And these are, if you look at this more, that the PVC is inferior axis and left bundle morphology. So coming from the RV, not LV, and the LV function is normal, and then the cath is this. And then patient got this bypass surgery. Question is that, is it LVOT or it is RVOT? Because RVOT without any coronaries is usually the normal. But here it looks like that there's significant coronary disease. And then we did the cabbage. I'm going to, I'm just giving you the flavor that we're still seeing COVID and we are diagnosing COVID from the EKG. I look at this EKG in the morning, the shoulder down, this is still going on, Wadud. We are still seeing this. Hypoxia, acidosis, and ST elevation. But good thing is that even our pulmonary fellows are not getting worried now and not calling us. But this is another important case, and I'll finish it with this one. Something that I learned. 73-year-old, she actually is the maid of our interventional cardiologist colleague. So I am on call and he is not on call. The maid actually told him that she is not feeling well and came to our hospital. And I beg your pardon, she's not a maid, she's actually babysitter. Her daughter actually is very well educated, and I'll tell you why that is important. So this is EKG. What do you think? Any comment on this EKG? And then when she came in, blood pressure was low. They put her on Levofed, chest X-ray is bad, and they were about to intubate. And this is the further EKG. And let me show you this EKG. This is better. ST depression in the precordial leads, and inferior lead now ST elevation. So Dr. Faisal Ahmed was showing the EKGs with the inferior, so circumflex or RCA, and then, but any comment?
I think it's inferior posterior involvement here.
The R is tall in V1 and the V2 looks like T wave is positive, but does it give any other comments about management of the patient?
So, and the question about
what is the P wave?
What's that?
What is the P wave?
Okay, so
well.
I will never say this, but I take this opportunity because Rafiq Bhai is not here. So in the acute MI, I don't even look at the P wave, but I'm not going to teach this to anybody. I look at tachycardia or bradycardia. Is it wide complex or narrow complex? Well, dude, I have simple rule. Less than 50 bradycardia, more than 100 tachycardia. If you see the P wave, fine. If you don't see the P wave, don't waste time to look for P wave. It could be RR interval irregular, maybe AFib. But if it is wide complex, be careful. Particularly wide complex skip rhythm in the face of bradycardia. Bad news. That some block infra-ICN block.
Yeah.
And the tachycardia is of course bad. So this is AFib, and then the patient had this inferior changes along with posterior. I agree with Azizul Bhai. But what we do next, that's the critical question.
You said his blood pressure is low, right? Is that correct?
Because you
despite
have
levofed of 10, the blood pressure is still hovering around 70. So I tell them that always do echo. And if you look at this echo,
MR, yeah.
MR is bad, Wadud, no question.
Yes.
And then look at one thing that we normally look at. RV is struggling, but not normal. And LV is terrible, right? And then patients, blood gas, significant acidosis, creatinine 3.5, and we don't know why, but the platelet count is 70. So I think also, and I'm telling you, you talk about resources constraint in Bangladesh, and I talk about we have resources, but sometimes it's not a good idea to use the resources when the upfront mortality risk is so high. So we actually told the family that we can put an Impella device cap and try revascularization, but it's a multi-organ problem. And they decided not to go for invasive strategy. It's a sad case, but it made me humble. Not always we need to jump on, but it is very important to give the patient's family total information rather than saying that we can do this, we can do that. And the patient coded afterwards, and like as we are talking, and they don't want the patient to be in chronic vegetative state. And that is a burden to the family to take care of this patient. So this is actually a good one. I'll probably show you next time because it is already running late. Maybe I will bring our EP guys who actually did the ablation, and then he can go through this ablation thing. I talked to him. You'll be happy to join the group if you guys want.
Oh, of course.
Okay.
Very interesting is this today.
So look at that. The number went to 87. It dropped to 58. So when it gets late night, it drops. So we need to be sensitive.
And the thing is that actually today there is very much electricity problem.
Oh.
I have been in and out.
Sir, it's been a fascinating 1 hour 45 minutes lectures and discussion. So it's quite late now. So I request Professor Abdul Chaudhary sir to wrap up the sessions, and we move forward. Wadud sir.
Thank you, Dr. Faisal and his mentor, our beloved Professor Ajam. And you have shown beautiful ECGs showing the different site of location that produces different aspects of ECG changes in the acute MI setting. And again, Hafiz Bhai, as always, has shown some wonderful ECGs of arrhythmias in different settings and the background that are very much active in producing this type of different presentation of arrhythmias. And that's very important. As Hafiz Bhai always says, look at the history, look at the background, look at the medication. And resources or not, if you are lacking in our hand, then that's the pity of everything we are trying to do. We have to think, we have to try, and only then we can improve. Again, thank you, audience. Thank you, the presenters, and thank you, our panelists and everyone. Thank you again for being with us. And Review and your team, as always, were wonderful. Thank you.
Thank you, sir. Thank you.
Want to see Faisal's other cases.
এই রিভু
হ্যাঁ ওইটা দেখতে চাই ও কিন্তু
জি, স্যার।
খুব সুন্দর একটা সিস্টেম করে
না,
নিয়ে
না,
আসছে
স্যার,
আজমের
এই-
প্ল্যানিং আর ফয়সালের ইমপ্লিমেন্টেশন গুড
এই জন্য বলছিলাম স্যার, আমরা ইনফিরিয়রটা কমপ্লিট করলাম, অ্যান্টেরিয়রটা সামনে আসবে।
এটা খুব সুন্দর হয়েছে তো ওই যে কথা
জি,
হয়েছে
স্যার।
যে কোন সময় দেখো ওই প্রথম কেসে যে কথাটা আসছে সেটা কিন্তু সে লাস্টের কেসটা দিয়ে দেখাই দিল
জি স্যার,
যে যখন এলইডি ডিপেন্ডেন্ট থেকে আরসিএতে তখন কি হতে পারে ঘটনা।
জি স্যার।
আর আরেকটা জিনিস আসলে দেখো প্রথম কেসটা দেখো ওই যে আমি বলতেছিলাম যে যে ইনফিরিয়র এমআইতে এই পরিমাণ স্টিচে শুধু আরসি এর জন্য হইতে পারে না, ওর আসলে তো 3টা ভেসেলে ডিজিজ আছে। এলইডি তো তুমি বলছো 60-70%, দ্যাট মিন্স
না,
সেটা একেবারে
স্যার,
ফেললাম না।
স্যার এই কারণে
অদ্ভুত, আগে আমি একটু, এখন আমি অনেক ঠান্ডা হয়ে গেছি।
না ওটা আইবাস করবো ভাবছিলাম স্যার।
আমি আগে যদি ফেলো পেশেন্ট না জানে ক্লিনিক্যাল পার্ট, ফেলোকে আমি ক্যাথল্যাব থেকে বেরো করে দিছি যে know the patient first and then come back. So it is very important to know the patient and the EKG, everything. But I'm like getting old. I'm not that bad now.
You are getting mellow.
And sir, the very important thing is that in presence of inferior MI, if we find ST depression in V456, that's a very alarming sign that the patient might have triple vessel disease. In presence of inferior MI, if we get ST depression in V456.
আমি একটা জিনিস আমার ইয়েদের বলি, রেসিডেন্টদের বলি যে no ECG changes, patient have classical angina, you are going to find triple vessel disease. There's balanced ischemia, canceling each other out, no change anywhere, but the patient have severe disease.
True.
I will find out another topic which is rare, but it's a very problematic, is the STEMI in cabbage patient.
Yes.
STEMI in cabbage patient is really problematic. Or for that matter, acute hot non-STEMI.
Sir, should we stop the webinar now and we
Yes.
we enter into the
I'm hungry now.
next meeting?
আচ্ছা তুষার,
Sir,
ঠিক আছে, তুমি হাফিজ ভাই আর ওয়াদুদ ভাই একটু ওয়েট করো, হ্যাঁ প্লিজ।
জি স্যার, আমরা স্যার রি-এন্টার করি ইসে, আমরা
আমরা চলে
স্যার
যাই।
আমরা কি লাইভটা অফ করে দিব?
আমরা
লাইভটা অফ করে দিই।
ওকে, আমরা কি লাইভটা অফ করে দিব?